So thank you very much for being here today. This is the second Asia Pacific webinar for 2026. It will be highlighting a case study on and discussion of thalassaemia from the Sri Lankan experience, presented by Chandrani Herath and hosted by the Global Nursing Network for Rare Diseases. As we start, we have a number of members from our international GNNRD community who might like to access live translations. On this slide, you can see a QR code. It is the easiest way to access these. If you've got a phone or mobile device, please use that to scan the QR code, and that should then give you live translations in a language of your choice. We will continue to run the presentation with you being able to view those live translations. After the presentation, we will open up the webinar for any questions and discussion. If you would like to ask a question or to comment or to speak in a language other than English, we'd ask that you please raise your hand either within the Teams function or just requesting to speak in a language of your choice. Please just bear with us a moment. We would change the translation link so that you can then ask that question or give that discussion point. I'd like to let everybody who's joined us know that today's webinar is being recorded. It's as a part of the GNNRD's education webinar series. Recordings are made available after the event on the GNNRD's YouTube channel and via our website, which allows members and the wider healthcare community to be able to access these educational resources after the event has completed. It's customary in Australia, where my team is based, to acknowledge the traditional owners on the land on which we work and meet, the Whadjuk people of the Noongar Nation. As a global network, we respectfully acknowledge the Native, Indigenous and First Nations peoples on whose ancestral lands we gather around the world, as well as the diverse and vibrant cultures that they represent. A few administration points before we hand over to our presenters and facilitators for today. Please keep your microphones muted during the case study presentation. We would ask that if you are able and comfortable to, could you please turn on your cameras? It's always wonderful to be able to see the global community and the people that we're connecting with through these events. We'd invite you to use the chat function to introduce yourself or to share things, to ask any questions, and also if you are having any technical difficulties, please place that in the chat also, and our team will endeavour to assist. To join the discussion afterwards, we will then open it and invite you to turn off your microphone to ask questions, to share any experiences, and to engage in some collaborative learning after the presentation. I'd now like to hand over to our leaders of the GNNRD's Asia Pacific region, Jasmine Go and Astelin Sur, who will invite you and welcome you to this Asia Pacific webinar and also introduce our featured speaker for today. Thank you, Jasmine and Astelin.
Hi, thank you, Jess. Hi, good afternoon, everyone. I'm Jasmine, and together with me, I have my co-lead Esther from the Philippines, and we are very honored to have our speaker from Sri Lanka, which is Mr. Herath Chandrani. So basically, Mrs. Herath is an experienced nursing professional, educator, and a researcher with over 3 decades of service in Sri Lanka healthcare. She entered the nursing profession in 1987 and completed her basic nursing diploma at the School of Nursing in Kurunegala. In 1991, she was recruited as a registered nurse by the Ministry of Health and began her clinical career at D'Souza Maternity Hospital. She later served at Teaching Hospital at the Kurunugala, gaining extensive experience in neonatal care, critical care, mechanical ventilations, and cardiac nursing. In 1998, she was selected through a comprehensive examinations to undertake training in management and supervision at the Post-Basic College of Nursing. She completed her diploma in management and supervision, including midwifery in 2000, and was appointed as a Grade 1 nursing officer at Teaching Hospital Kandy, where she functioned as the unit manager of the surgical intensive care unit. She was subsequently promoted to special grade nursing officer. Mrs. Herath obtained her Bachelor of Nursing degree with upper class honors from the Open University of Sri Lanka in 2008 and began serving as a visiting academic in 2009. She also holds a Master of Science in Food and Nutrition and a Master of Public Management. And in 2001, she joined the Faculty of Nursing, University of Colombo, as a lecturer. She is currently a researcher and a PhD candidate specializing in children's health, women's health, and nursing leadership. So let's welcome Mrs. Herath with her thalassemia and the Sri Lanka experience topic for today. Thank you.
Thank you very much for your kind interaction. Let me share my presentation. I hope you all can see my presentation and also am I audible?
Can see your
Yes,
presentation.
Chandrani, everything's looking wonderful and we can hear you clearly.
Okay. Thank you so much. Good afternoon, everyone. Thank you so much for your kind introduction. I highly appreciate you giving me this opportunity to share my experiences. Uh, I'm HMCM Herath representing Sri Lanka. I will mainly walk through the nurse's role in caring for patients with thalassemia in the Sri Lankan context. These are the learning outcomes of today's webinar. First, describe the global and Sri Lankan epidemiology of thalassemia. Second, differentiate between thalassemia types and severity classification. Third, apply advanced nursing assessment and monitoring skills across the transfusion and iron chelation continuum. Fourth, evaluate the psychological and impact of thalassemia across the lifespan and select appropriate nurse-led screening tools and intervention. Fifth, appraise nurse-led models of care. Finally, synthesize current gaps in national thalassemia in nursing practice and propose evidence-informed strategies. Let us see the Sri Lanka's landscape, population, and healthcare system. Sri Lanka is an island nation of about 23 million people in the Indian Ocean, ethnically diverse with a universal free healthcare system alongside the private sector. The total land area is 65,600 square kilometer diverse terrain. The population consists of Sinhalese majority, Tamil plus Moors and others. Healthcare is provided as universal free public system. The private sector offers additional options alongside. Thalassemia is one of the world's most common single gene disorder, yet it's still classified as a rare disease in high income countries. Globally, about 7% of the population carries a hemoglobin gene disorder, roughly 300,000 plus severely affected infants are born every year, and 56,000 of those have severe disease. The highest burden belt runs through the Mediterranean, Middle East, and South Asia and Southeast Asia. And Sri Lanka sits squarely in it alongside Thailand, Cyprus, and Iran. This shows the classic thalassemia hemoglobinopathy, belt shaded across the Mediterranean and Middle East, South Asia, and Southeast Asia, with migration arrows carrying the gene towards North Africa, Europe, and other traditionally low burden regions, visually reinforcing that 5.2% of the global population carries a clinically significant hemoglobinopathy gene, and that this is no longer geographically contained disease. This is the national picture. Sri Lanka has roughly 23 million people, about 45 to 55 new beta thalassemia major births every year, roughly 2,000 registered patients with severe disease cared for across 23 treatment centers island-wide. The carrier rate is 1 to 2% nationally, higher in specific communities, and the sobering number to sit with. Annual major thalassemia births have not meaningfully declined in almost 19 years despite investment in prevention. So this map highlights the Sri Lanka's uneven thalassemia burden, with Kurunegala, where I'm living, my hometown is, standing out as a high concentration hub connected to Anuradhapura and Ragama, alongside the national headline figures of 2.8% beta carrier rate and estimated 2,000 plus transfusion dependent thalassemia patients requiring lifelong care. Now, let us see the definition. Thalassemia is a heterogeneous group of inherited genetic disorder caused by reduced synthesis of either alpha or beta globin chains of hemoglobin. This impaired globin production disrupts normal red blood cell formation, resulting in a hypochromic, microcytic, hemolytic anemia that typically manifests in early childhood. The clinical severity varies widely, ranging from asymptomatic carrier state to severe transfusion dependent disease. Moving on to etiology, autosomal recessive globin chain imbalance is the mechanism. In beta thalassemia major, symptoms typically surface after 6 months once protective fetal hemoglobin is replaced by adult hemoglobin. Ineffective erythropoiesis and hemolysis drive chronic anemia. Iron overload from transfusions can further damage the heart and liver. We'll see alpha versus beta. Alpha depends on how many of 4 genes copies are affected. 1 gene, silent carrier, 2 gene, triads, 3 genes, HBH disease, 4 genes, beta buds or hydrops, that is often fatal in utero. Beta is classified by severity, minor or triad, asymptomatic, intermediate, moderate anemia or sporadic transfusion, major or coolest anemia, severe transfusion dependent for life. So that is what I previously talked about, severity of the beta thalassemia, minor, intermediate, and major beta thalassemia. So this 2 by 2 matrix organizes thalassemia by transfusion dependency against globulin defect, clarifying that beta TDT is the most clinically demanding quadrant, uh, requiring lifelong maintenance of HB more than 90 gram per liter. Pre-transfusion HB around 90 to 105 gram per liter in most patients. Some patients require 95 to 110 gram per liter depending on complications. This slide shows genotypic landscape and clinical implications. Beta thalassemia major, transfusion dependent from infancy, which require the highest nursing intensity. HBE beta thalassemia, mild to transfusion dependent, needs individualized assessment. Intermediate, non-transfusion dependent, often under-monitored for silent iron loading, and sickle beta thalassemia, sickle cell complications plus thalassemia iron loading, that is dual disease burden. So we'll take a look at the services which are available in Sri Lanka. National Safe Marriage Prevention Program under the Ministry of Health, that is voluntary premarital career screening based on the concept of safe marriage, at least one partner, not a career. Since selective abortion is legal in the Sri Lankan context, target population school children age 15 to 19 years, community health education lectures followed by screening and genetic counseling, mainly in 5 high prevalence districts rather than nationwide. There are 23 management treatment centers having 1 bone marrow hematopoietic stem cell transplantation center, which is in the Colombo. 2 identified Sri Lankan patient support NGOs available: Sri Lanka Thalassaemia Circle and Thalassaemia Foundation for adult patients. There is an international link as well. Sri Lanka is represented in the Thalassaemia International Federation network through academic or clinical leadership. These pictures are from National Thalassaemia Center, which is in the Kurunegala. So last week, some of these pictures were taken with permission to illustrate the ward congestion. One child is receiving blood transfusion and the other is receiving iron chelation therapy. We'll see why nurses are the cornerstone of care. Unlike many rare diseases, thalassemia require regular, lifelong clinical care with transfusion dependent patients attending every 3 to 4 weeks. This enables nurses to build enduring therapeutic relationships, providing continuous care and support throughout the patient's life. Moving from survival to quality of life. In the 1970s, survival in well-resourced settings was under 10 years. Today it's 40 plus years, but the cause of death has shifted from anemia itself to cardiac iron overload, which now accounts for 71% of deaths in inadequately chelated patients. So, we solved survival, we have not yet solved quality of survival, and I hope that closing that gap is a nursing job, not just a medical one. Moving towards the healthcare system context, blood transfusion and chelation therapy are provided at no direct charge, which is genuinely significant, but that some system create a specific nursing challenges, uneven resource allocation across centers, inconsistent quality of care, and hidden costs that fall on families. Transport, lost wages, time. Cost the system does not measure, but families feel every month. A study reveals that the hospital cost per patient per year is USD approximately 2,601. Treatment is free, the disease is not, and nurses are often only ones who see that gap up close. We will walk through blood transfusion services in regards to nursing sciences. Pre-transfusion nurses should focus on HP target 9.5 to 10.5 gram per deciliter, and also weight, vitals, clinical status, a spleen size, blood pressure, cardiac status, growth monitoring, and alloimmunization should be monitored. Transfusion administration standards are leukopleted, phenotypically matched cells approximately 5 ml per kg per hour, slower if cardiac compromises. Post-transfusion target is 13 to 14 gram per deciliter. Watch for febrile allergic reactions and infection screening. So these are to be done by the nurses. This is flag, which is a specific risk in Sri Lanka, alloimmunization. Alloimmunization affects 4 to 22% of multi-transfused thalassemia patients in Sri Lanka. Limited access to extended red cell phenotyping makes nurses essential in accurately documenting transfusion reactions and sorry, advocating for appropriate cross-matching to improve transfusion safety. We will take a look at the silent killer. Each unit of pack cells delivers approximately 200-250 milligram of iron. Patients receive 12 to 24 transfusion per year against an excretion capacity of only 1 to 2 milligram per day. The arithmetic of overload is inevitable without chelation. I will walk the organ table quickly. Heart, arrhythmia, and cardiomyopathy, leading causes of death. Liver, fibrosis, impairs chelator metabolism. Endocrine or pituitary, growth failure and diabetes, pubertal failure, bone, osteoporosis. Nurses are having critical responsibilities in iron chelation therapy. Here I have shown the drugs that we are using in the Sri Lankan context. Deferoxamine, SCOIV, that is gold standard but high burden for the country. So then audiometry, ophthalmology and infection site care should be done by the nurses. Deferasirox, that is oral, most used in Sri Lanka, monthly renal function, GI effects, and hepatic enzymes are to be monitored. The other drug is deferriprone, that is oral, best cardiac iron clearance, mandatory weekly WBC for agranucleotosis risk. Combination therapy for every cardiac iron. Normally give the numeric targets. Nurses should hold patients to ferritin less than 1000 microgram per liter. Reassess above 2500. Cardiac T2 less than 20 milliseconds. Loading less than 10 milliseconds. Severe or urgent liver iron less than 7 milligram per gram dry weight. A study demonstrated that 62.5% of patients were adherent to chelation, and non-adherent patients had significant higher ferritin, more than 2,500 microgram per liter. Critically, knowledge alone did not predict adherence. That's the whole argument for behavioral nursing interventions over patient education leaflets. Then what works? Motivational interviewing. At least 3 per week for the first 3 months. Approximately 40% adherence improvement. SMSO apps reminders 28 to 35% favor missed doses. Peer support and adolescent empowerment clinic. It is meant to be never normalize a ferritin of 3000 to 5000 as acceptable in a resource limited setting. So, challenge it, escalate it, act on it. That is up to nurses. So as we all know, Patients and family members have a psychosocial burden, mainly depression, anxiety, affect 20 to 40% of major thalassemia patients higher in adolescence. So, a screening with PHQ-9, GAD7, PETSQL at every routine visit, not just when something looks wrong. Unfortunately, in the Sri Lankan context, we are not using any of these. Then body image, facial bone changes, growth failure, visible chelation pump mark. Need to sensitive communication and peer support, not silence. Social isolation, a school absenteeism, a stigma are real in South Asian communities. Nurses can lead the school reintegration and teacher education. The other one is existential and sexual health issues are frequently the least discussed. Fear of death, fertility concerns, delayed puberty, and need proactive nurse initiated conversations, not patient initiated disclosures. This slide outlines 5 interlocking family impact domains from the Sri Lankan literature. Isolated and neglected caregivers, usually mothers, siblings falling behind at a school for lack of attention, marital strain from combined financial and caregiving pressure, parental job loss from monthly transfusion visits, and near universal parental guilt over having transmitted the disease. So, by looking at this, we can see the family impact. This slide argues that thalassemia already demands 5 distinct competencies from nurses. That is, clinical expertise, education, uh, coordination, research, and advocacy, but currently ask them to perform all 5 informally with no defined roles, no national competency framework, and no formal recognition. The thalassemia nurse, a specialist, which is established in some other countries, simply names actually then legitimizes what capable nurses are already trying to do piecemeal, manage transfusion, iron protocols, educate families and schools, coordinate the MDT and transition care, contribute to audit and research, and advocate with the Ministry of Health and international bodies like TIF. We are not asking for a new job. We are asking for formally recognize the job nurses are already doing without the training, title, or authority that should come with it. The other need is genetic counseling. Genetic counseling is Sri Lanka's biggest stagnant opportunity. Births have not dropped in approximately 19 years in the gap is trained personnel for non-directive, culturally sensitive counseling, one that has to work across Buddhist, Muslim, Catholic, ethically framework simultaneously. So field work around the MDT wheel, nurses central coordination position across all 6 domains. The nurses coordinate across cardiology, endocrinology, hepatology, psychology, social work, and hematology. Often work and hematology, often by fall, so it has to become deliberate. So we'll move on to see digital health and M-health in nursing. Digital health mobile apps and dashboards improved chelation adherence by 28 to 35%. Teleconsultation reduces the transport burden for rural families, and WhatsApp based peer groups pair naturally with nurse monitoring. Sri Lanka's more than 120% mobile presentation mean this is not aspirational, it is already in patient's pocket. So, a WhatsApp message reminding a patient to take their Ferrosirox tonight is nursing care that we can do. So these are key challenges in Sri Lanka thalassemia nursing. Disease mean to learn as intellectual honesty, not criticism. Unavailable cardiac MRI in most centers. No national nurse specialist training program. Preventing birth rates unchanged for 19 years. Geographic inequity, especially in northern and eastern provinces. Weak mental health referral pathways, and no national outcomes registry. Actually, this is a deliberate. This is deliberate. In the title is not a typo. It is the point we are looking for. This is a 6-point roadmap, national certification, nationwide genetic counseling, a standardized screening, and outcomes registry, international partnership, and formal transition programs, whose completion date is left unanswered because it depends entirely on whether the system choose to act, not on the calendar. Our nurses can decide which priority is the most actionable in their own center. So let us see the 5 informative nursing imperatives. First one is know your numbers. A ferritin over 2500 is not acceptable. So then challenge it, escalate it, act on it. Second, see the whole person. Behind every hemoglobin level is an adolescent, a mother, a father making impossible choices. Third, master your transition. Ages 16 to 22 are when patients die from preventable cardiac iron overload. Fourth, build evidence, document, audit, publish. Finally, advocate relentlessly. Your patients cannot always advocate for themselves. You can. So, this is the last one that I want to emphasize. Thalassemia nursing is not just a specialty, it is a lifetime commitment. To transform survival into quality of life, we must bring our full science, our full compassion, and our full advocacy to every patient's encounter. So, that is that's need to make a decision. So, the nurses are the people should assess the patient. In my point of view, uh, based on this scenario, repeat confirm vitals and clinical status. With the low hemoglobin, there may have some other clinical features as well, which previously the patient had not, like fatigueness, breathing difficulties. Therefore, assessment of the clinical status is very important, including weight, blood pressure, spleen size, and some other growth parameters as well. The other thing that we can go for even though nurses are not much involving in cardiac screening check, we can just convey the message to the doctors, and then doctors prescribe ECG and then cardiac T2 MRI as well. So the nurses should ready the patient to send for the ECG or cardiac T2 MRI. Adherence history taken directly and non-judgmentally. So we cannot judge anything. So then we need to collect all the information to see whether the child has adhered to the uh, chelation therapy. So ask about deferoxirox, how often he has taken, and then what gets in the way, like what is the taste, then we can identify whether he has taken or not, and forgetting the drugs and embarrassment as well. So likewise, once we take history, we need to ask some probing questions to get some more informations. Documentation about the fatigueness and school absenteeism, then initiate psychosocial screening by using relevant kind of tools, even though in the Sri Lankan context, we are not using, we just ask some questions and try to identify what is happening, what you want to do, what would you expect likewise. So open conversation should be done. Mainly what we can do is having an open conversation to get the history accurately. Otherwise, some of the patients are hiding their histories. So mainly as we nurses under the nursing assessment, immediate assessment, these are the things that can be done based on the scenario. So then second question is, given the ferritin trend, what does this suggest about chelation adherence and what evidence-based nursing intervention could you initiate? So it is obvious, like ferritin level is 3,150 above to the 2,500. So then we can arrange for reassessment of the iron levels. So then we can go for the ion chelation therapy, and motivational interviewing also can be done. And what we can do some others, like using mHealth reminders. In the Sri Lankan context, we are using WhatsApp messages, SMS messages. There is a system, so then we can remind. But the thing is that as we are running our services with the shortage of nurses, very oftenly it cannot be done. So even though the system has established, sustainability is a question. So then investigation can be done. So then we have to ask the patient to come to the hospital and get admitted, and thereafter some of the investigations are to be done based on their clinical conditions. So likewise, based on the ferritin level, some of the nursing management we can do at our levels. So by looking at the Sri Lankan context, applying the family-centered care principles, then we are doing it. But the thing is that there are multiple problems. So the socio-economic level is highly different. So then if someone is having high socio-economical status, uh, family support is very high. If someone is in the low socio-economical status, family support is very low. As I mentioned in the lecture, so then if a mother or father is getting wages, so then they will be losing their wages if the child is accompanied to the hospitals. Likewise, there are multiple problems related to the family centered care. Anyway, what I have experienced here even though they are losing their financial things, they are doing maximum for their children. So that is what we can appreciate in the Sri Lankan context. The thing is that some people live in very far away from the thalassemia centers. In that sense, they have to travel for hours and hours to reach to the thalassemia treatment centers. So that is also another problem. So then they are losing their other siblings as well. So sometimes other siblings, like other children in the family, losing their education as well. So then currently, when comparing to the previous situation, currently most of the children, those who are suffering from beta thalassemia, engaging in studies. So what I previously experienced, they did not, I mean, drop rate was high. Now the drop rate is comparing to the uh, previous decades, drop rate is very low. So then there are patients who are entered into the law college. So there is a nursing officer as well. So they are managing their ferritin level very nicely, and they are engaging in different activities and motivating other people. And so they are well known about the disease condition. They are like, sometimes I feel that like a specialist. So they search now, they can access to the AI as well. So then they search and learn and share with the peer groups as well. In that sense, applying family centered care principle, in some situations it is limited, in certain situations it is highly uh, applied. So then final question is, what does the case illustrate about the gap between Sri Lanka's free healthcare system and real world burden on families? So I mentioned that expenses of the out of pocket. So that is also high concern. In that sense, there are certain facilitation systems, like there is a department called probationary, that is under the government. So then monthly 3,000 rupees, that is a small amount when comparing the cost of living, but a small amount is given to a family, at least to recover the travel cost. And also there are certain associations, as I mentioned, they are also supporting. So annual trips are arranged. Likewise, I mean, certain level facilities are available in addition to the free healthcare system. Even though I mentioned here, we do provide free healthcare system, uh, resource limitation, and other, I mean, when it comes to the resource, even human resources are very limited. All other resources are limited. Sometimes they may face with the shortages of the drugs as well. Sometimes the patients may feel like uh, they are unable to get even blood transfusion. Blood bank is running shortages. Likewise, the thing is that to fill the blood bank, so our people, general people, willing to give their blood. I mean, there are blood donors. So then blood donors donate the blood. So then blood bank is filling. Sometimes blood bank announce that they are running with shortages. So then with the announcement, people come and donate the blood. And also if the hospital or someone announce that we are running short of some drugs, there are some donors, they are coming and donate some drugs. Likewise, there is such a system. If that system is not adequate, so then family members will have to bear the cost. So those are the basic things that I can mention here under the discussion. So I hope that uh, you all also can add something in regards to the questions which I have discussed. So then these are the references which I have used, main references which I have used. So this is the time for the questions and answers.
Thank you, Mrs. Harris. Thank you for your wonderful and insightful presentations. I have really learned something from you, and this is a session that is very informative and valuable for us. So at this point, like you mentioned, so we would like to open the floor for any questions. And if you have questions, feel free to type in the chat box or unmute yourself to ask the questions. Actually, I have a question. Do y'all have like a general blood bank or that will do blood donation on a regular basis?
Yeah, each center we do have a blood bank. Say, for example, I mentioned about National Thalassaemia Center, which is located in the teaching hospital Kurunegala. So there is a blood bank having all the facilities. There are certain centers which are not having blood banks. So then there is a national blood bank. So then they get the blood packets from the national blood bank as well. So even with shortages of the blood bank, sometimes blood packets, sometimes they may make a request from other blood banks. They are sending blood packets to the relevant center. That is how we are managing blood transfusions in the centers.
I see. So which means that there will still like if let's say another cities are lack of blood, you can actually transfer the bloods over.
Yeah, yeah.
Uh,
So for example, if the teaching hospital Kurunegala lacks in blood, so then we can make a request from Colombo National Blood Bank. So then they send the blood packet to the Kurunegala. So that is how
ah,
normally we manage. The other thing is the if we announce, if the center announce that we are lacking in blood packet, normally the people gather and donate the blood.
okay, sure. So that donation is not on a regular basis, like 1 year, how many times?
There is a regular basis donations as well. Some societies, there are some societies in the Sri Lankan context, they arrange every month. Some organizations arrange every month, some organizations arrange once a year. Likewise, regular basis blood donation camps are available. So then centers like Teaching Hospital Korunagal visit the area, geographical area, collect the blood and take them to the center.
I see. Okay, I think I have asked enough. I open the questions for others to have a chance to ask. Anyone? Jasmine?
Thank you. That was such a wonderful presentation, and I have so many questions that I think I could ask. But I guess my curiosity is very much around, with survival age increasing so significantly, it changes the focus of care very much, to thinking about that long-term management, comorbidities, and then even as you're talking about, there's more need to consider how we engage these patients with education, work opportunities, and because if they're going to live longer, they need to then be able to manage all of those additional things. And I wonder how rarity of the disease impacts that for you in Sri Lanka. Is it more difficult to drive resources into that management because it's considered a rare condition? And if so, how do you lift the importance?
Thank you for your question. Actually, I said that we are living in a resource limited country. With that
Mm.
also, we were able to extend their lifetime. So then I met one patient, his age is 45 years. He's a millionaire actually. He's a businessman. So then he can earn a lot. So then such people donate mainly to the hospital settings. With that only the services are managed. And then there are some varieties as well as you mentioned. So then, but the thing is that at the beginning, if the condition is diagnosed, frequent visits are conducted. We do have a provincial system as well. So then there are centers which we are running, and also provincial system is supported to the centers. So then, for example, education and updating the knowledge of the school children and other marriage age categories also is done by the provincial healthcare sectors. Right? So then when it comes to your question again, uh, then actually the services are well provided. Services are well provided. So then there are some consultants, those who are very interestingly engaged in. So then they dedicate on providing services. Right? In that sense, we were able to expand the lifespan. So it doesn't mean, I mean, I talk about 45 years a man, but the thing is that there are some deaths less than I mean, around 15 years also we can see. But the thing is that when comparing to the previous situation, it has been expanded. Are you okay with my answer?
Yes, thank you very much. I'll pass on to our final question. And I might just ask if you stop sharing your screen, if able, while we move to the next question, just so we can see everybody online more clearly.
Yeah.
And we might then close after this last question. So
I hope.
I think you might be muted, Jasmine. We'll come to Tresna. She's got her hand raised.
Hi, Chandrani.
Hi.
Firstly, I just wanted to say your English is incredible.
Thank you.
Well
I'm not a
done.
native speaker.
There were some words there that I couldn't even pronounce, so well done.
Thank you.
You mentioned the incidence of anxiety and depression, and those rates are really quite high in these thalassemia patients. You also mentioned that currently there's a validated tool is not being used routinely. And that it is part of the vision for it to become a standardized a practice within the clinics. What do you think could be done to help introduce that?
Actually, we are keeping some steps. So I'm engaging in to keep a step. So because I do have a connection with the Ministry of Health as well. Very recently, we developed a certificate course for hematology nurses. Likewise, step by step, we are moving ahead. So we had no pain nurse. We created a pain nurse. So then hematology nurse with use of small certificate courses, we are developing certain specialties, even though that name of the specialty is not given. Because we are a doctors dominant society. That is the problem. So then nurses are not giving opportunity to go ahead, keep their steps forward. So that is the actual scenario in the Sri Lankan context. Anyhow, we are struggling with all these things, and we are facing some problems, and we are trying to do. So then uh, uh, creating counselors, genetic counselors, as well as thalassemia specialists. That is only for the terminology actually. Expert nurse, making a thalassemia expert nurse is our target. So then I hope that it could be done. So then we are in the initial process of creating a expert nurse in thalassemia and also the genetic counseling. Recently, so then I'm working in the Faculty of Nursing. for the nurses curriculum, we have added genetics in nursing. So previously we had no. So then they have chance to learn more on the rare diseases and genetic related disease conditions. Likewise, a step by step we are moving onward.
Wonderful, thank you. I'll pass back to Jasmine or Astelin if there's anything final that you'd like to say in wrapping up the discussion for today.
No, I think this is really a great interactions. I think we all
Yeah.
learned a lot from each other. And maybe I like Esther. Do you have anything that you want to say?
Just a brief insights from this webinar. Thank you so much, Chandrani. It's so informative. While you are talking, we are thinking on how we can duplicate that in the Philippines. So anyway, as the incidence of thalassemia is increasing not only in Sri Lanka but globally, hence nurses are faced with many challenges, no, such as, for example, nursing competency to manage long-term management of patients. And then uh, I like the statement you said that we are not supposed to address only the survival, but we have to ensure that uh, patients are living a quality life or survival. And then, of course, we have to increase our knowledge in attending the psychological, the socioeconomic concerns of our patients, especially if these are all genetic disorders, because these patients are our patients for life. So, and then, of course, education does not only the nurses should be also equipped with knowledge not only on the understanding the disease but the genetics of the disease, no. So during our meeting with Chandrani, I was in fact sharing to her that here in the Philippines we are already training nurses on how to counsel patients with thalassemia, no. So although we have genetic counseling already course here in the Philippines, but due to the absence of many genetic counselors in other countries, we train nurses. So I don't know, probably we can include this, Jasmine, in one of our activities in Asia Pacific, so that we can address the problem of address Chandrani's challenges, no. So probably this is where GNNRD can assist our members in other countries, no. So in the Philippines, so Chandrani, thank you so much for this very, very informative, very insightful presentation. And also, I think that's it. So there's a challenge for all of us, and I hope GNNRD globally and Asia Pacific can assist Sri Lanka in these challenges, facing these challenges. So that's it. Thank you so much again.
Thank you. Back to Jess.
Wonderful. Thank you so much again, Jasmine and Astelin, for organising this incredible series. Thank you so much, Chandrani Herath. That was a wonderful presentation. It has spurred so much food for thought and insight into the challenges, but also the potential for shared learning. So very grateful for your time. This link was shared as an open link, so I'm aware that some attendees may not currently be GNNRD members, or those that view it after the event via YouTube might not be GNNRD members. We invite all nurses around the world with a level of interest in rare or undiagnosed disease, or with connecting with other nurses to improve patient experiences and outcomes in this field. Please join the GNNRD. It's free for all. There's a QR code on your screen right now. But thank you again, everyone, very much. It's been a wonderful experience. We look forward to seeing you next time.